So today I want to go back again to some kind of basic principles. This is kind of really basic in some ways, but I think it's very important to see how clinicians are using some imaging, and especially in this case, Doppler, in order to evaluate cardiac function or hemodynamics. And also in some of the next classes, we would go towards looking at, for example, diastolic function and so on. And for that, I think it's really, really important that these very, very basic things are also clear. So I'm sorry that it's reasonably simple, but I think it's important to do these things, and especially kind of point you to a couple of things which are actually relevant in order to understand how clinicians are using some of these techniques. So today I want to talk a little bit about particularly about Doppler techniques and how you can quantify things with Doppler, so that then in the next sessions we can see how you can use this for really clinical applications. So as I said before, in some of the previous classes, is what you always have to keep in mind is that the heart in itself is a volume pump. So you need to generate the cardiac output, so the amount of volume per minute that is needed by the body under certain circumstances. So that can be at baseline, or that can be during exercise or something like that. So that's the most important. You need to generate volume. So this generation of volume flow needs to be done under all cardiac conditions. So that means with changes of an individual to the adaptation that body needs, so it needs to be flexible for that, but also it needs to be changing with disease, something like that, or while a person is growing, or while you gain or lose weight, for example, while you age, because your periphery changes while aging, or if you have certain cardiac diseases. So all of this, there have to be adaptive mechanisms so that the heart as itself can keep on generating this volume. Now, obviously, from hemodynamics, you know that you can only have flow if you have a pressure difference. So by definition, you can only have flow for pressure if you have pressure gradients. So looking at pressure gradients is important. Looking at absolute pressures is, of course, important, because there is a certain range of pressures at which the body, again, is optimized, so where your vessels are optimized and things like that. But what is also very important is that you need to have these pressure gradients that create the flows in some ways. We will see that actually it's much easier to measure pressure gradients than pressures with Doppler. There's a big advantage, and pressure gradients are obviously important. And then, as I also told you before, is also this link between the volume flow that is being generated and then how this is done by deformation. That's important to understand, especially cardiac remodeling. But today we're going to mainly look at how we can kind of assess flows and pressure gradients using particularly then in this case Doppler flow. So also then let's go back to the cardiac cycle and look at some properties of flow which are actually important to understand and know or evaluate in order to look at function, for example. And one of the things that you see is when you look at how the flow is going within the heart, then you can actually, for example, nicely see, so as we said before, so we have flow which comes first in the atrium. So say that we start from the lungs, the flow comes in the left atrium, then into the left ventricle, and then has to go out of the ventricle through the aorta. And then again, it comes also from the right side. But if we concentrate on the left side, so you see already a couple of things which are important. So first of all, what is important is like, how is the blood going from the atrium to the ventricle? That's in the end also what we call kind of filling, or which is related to diastolic function. Then the other thing that you also see is that what we see is that the flow has to turn because the mitral inlet and the aortic outlet, they're actually more or less in the same plane. So that means that there has to be a change in direction of the flow. And that is done by, in some ways, some kind of vortex formation around the apex. So that's also why the geometry is quite important, because the geometry, and especially also like the trabeculations in the endocardium, they will determine how these streamlines, these flow patterns are developing within the ventricle. And all of this is, of course, as we said before, generated by pressures. And what is important is to look at this kind of combinations of pressures and flows. And so here you see like a kind of a schematic view of some of the pressures and flows. And we'll come back to that also when we talk about filling and function. But a couple of things are already important to notice. So we have, of course, the pressure in the ventricle, which is like becoming from very low to very high. So this is actually like a huge difference that you have. And also, obviously, the opening and closures of valves are based on pressure gradients between, in one case, the atrium and the ventricle. So the mitral valve can only open if the pressure in the ventricle is lower than in the atrium, because otherwise the valve cannot open. And similarly, also with the outflow, so the flow can only start if the aortic valve opens, and the aortic valve can only open if the pressure in the ventricle is higher than the pressure in the aorta. So that's what you can see here. So at the moment that, because of the onset of the contraction, the pressure in the ventricle rises. When the pressure becomes higher than the pressure in the aorta, then the aortic valve opens. And what you then see is that there's a certain pressure dynamics. We're not going to go in detail now, but we come back to that later on. So we see that actually left ventricular pressure in a normal heart peaks very early on in the ejection, about roughly 1/3 of the ejection phase, and then starts to drop because of the fact that you have a decrease in the contractile force. But of course, when we look at the flow, so the flow is accelerating while the pressure in the ventricle is higher than the aorta, and starts to decelerate at the moment that the pressure of the left ventricle becomes a bit lower than the aorta. But only when the flow is zero, the aortic valve will close, obviously. So one thing is that you have the pressure difference between the valve, but next, of course, the valve can only close if the flow stopped. And for that, you have to decelerate the flow. So the inertia of the flow is actually a quite important component. And then similarly, you start to get inflow in the ventricle when the pressure of the ventricle drops below the pressure of the atrium. And then we have the kind of early relaxation, as we say. So the early filling period, that will cause a velocity in the mitral valve. So you start to see flow going from the atrium into the ventricle. And then later on, when you have atrial contraction, we see that the pressure in the atrium, of course, becomes higher for a while than the pressure in the ventricle. And that causes the second wave of filling. And related to that is the pulmonary vein, but we'll come back to that later. So what we see here is that these pressure gradients are important. And then we see that, of course, these flow profiles will tell us something indirectly about these pressure gradients. And that's actually how we will start to do our measurements. So then when we're talking about cardiac hemodynamics, so we want to assess hemodynamics, and hemodynamics is obviously, by definition, dynamics of the blood flow. And dynamics means the temporal behavior. And so because of the fact that we have a pulsatile cardiac function or cardiac contraction and cardiac flow, it's a dynamic phenomena. And this dynamics is important because both the onset of the contraction, the onset of the flow, so what happens there with the dynamics, as well as the bulk dynamics, and what happens with the filling and so on, and how this is changing with disease, that actually is important. So which are the components of kind of blood flow dynamics or blood dynamics that are important? Well, first of all, of course, the volume. So measuring volumes, measuring how much volume is being ejected with each cardiac cycle, that's important. Now, other volumes is like in a normal circulation, as we said before, we have a serial connection of different components, and the flow is unidirectional. And that actually depends on valves being there. But obviously, there's a couple of things that can go wrong. First of all, we can have problems in these valves. We can have leaking valves, for example. So that means that instead of that the flow goes in one direction, we can have bidirectional flow over valves. This is something that we need to be able to measure. But of course, also, since the heart is a complex organ, and of course, development is complex, but also we can have trauma due to accidents or things like that. There might be some connections between components of the circulation which are abnormal, which shouldn't be there, and make actually that, again, this unidirectional flow is kind of for some way compromised. So a very typical one is, for example, what we call an ASD. So that would be an atrial septum defect or ventricular septum defect. But we can also have some connections due to abnormal vessel connections, due to holes in vessels or connections between vessels that should not be there, or some fetal connections that are not closed at birth while they should be. So there's a lot of ways that we can have abnormalities related to this unidirectionality of the flow, and we should be able to calculate how much volume is going in the wrong direction, let's say it that way, because that will make that the volume is not going in the right direction, is not going, for example, through the lungs, or that we can get mixtures of oxygenated and non-oxygenated blood, and all of these are important to measure. So then looking at this valve geometry itself is also quite important. So because besides leaking of the valve, and if we have a leaking valve, we want to know why this is leaking. Is that because the leaflets don't coapt properly? Is that because the leaflet is somehow abnormal in shape? Is there a hole in the leaflet? For example, with a bacterial infection, like what they call endocarditis, it could be that bacteria are kind of eating away valve tissue, and you can really have literally a hole in a valve leaflet. So all of these things are important to be able to evaluate. And of course, besides a leaking valve, what we can also have a valve which doesn't open enough. For some reason, it doesn't open. It's kind of blocked partially or obstructed partially. It's what we call a stenosis. And we need to be able to look at this stenosis. And also, if we have these abnormal connections, we want to know not only how much volume is going through it, but we actually would like to know what's the geometry. How big is this hole? Because that might be relevant in order to do a repair, to do a surgical repair, or to put a device or things like that. So these are the things that we would like to measure. And of course, besides these flows, because what I told you is flow is induced by pressure gradients, so it will be interesting to measure these pressure gradients directly. And so, of course, filling is determined by the pressure gradients between the ventricles and the atria. The ejection is determined between the ventricles, the pressure gradients between the ventricles and the large atria, but they can be, of course, also different things. So that can be important, namely absolute pressures besides the pressure differences. But as I told you before, absolute pressures are very difficult to measure, but we can find ways to estimate these. And some of the things what are important is like, what is the lowest pressure that can come in the ventricle? Because that's very, very important for filling, and actually also is very determinant for a lot of kind of symptoms which are related, for example, to heart failure. Because if your pressure is too high, what happens is that the blood cannot go through the lungs anymore in a normal way, and you start to get what they call pulmonary edema. So where volume or where fluid remains within the lungs and then starts to block these, for example. And so these end-diastolic pressures and atrial pressures, and then the pulmonary artery pressures. So all the pressures which are related to the lungs, the beginning of the lungs, the end of the lungs, and then the filling, the connection to the ventricle. These are actually very, very important for symptomatic control of heart failure patients. And then, of course, it's like, how is this pressure generated dynamically by the ventricle? That tells us something about the force development by the ventricle. So these are all the things that we would like to assess. So we have to find ways in order to look at these and in order to measure these. So when we're using ultrasound, we actually have quite a lot of modalities at our disposal, some which are related to geometry. So where we really look at the geometry, the morphology of the ventricles, and especially its dynamics. So we can measure the volume at end diastole, the volume at end systole, and we know that the difference between it is the stroke volume. Or even if we are able to segment it during the full cardiac cycle, what we will see is then we can look at really at the dynamics of this flow, and we can have actually some information not only about the absolute stroke volume, but also about like how it evolves temporally. A very, very useful tool, as I said before, is Doppler, and that's what we're concentrating on today. And Doppler mean, when you look at the cardiac literature, Doppler is not kind of sexy nowadays because a lot of people perceive it as old and things like that. But actually in clinical practice, it's very, very important. And actually, there's a huge amount of more information in the real detailed dynamics of the Dopplers than that is mostly used in current clinical practice. Because I told you before also, it's like, especially also with all these new fancy techniques and things like that, is clinicians want to find ways to find a simplified parameter that kind of explains everything in some ways. But unfortunately, life is much more complicated, as I told you before. So we really need to try to integrate information, and Doppler is quite interesting. And for those people that are working nowadays also in machine learning, that's exactly what we can try to use in order to look more at these real dynamics of the Doppler, and then look at how these flows are changing and how, at the end, pressure gradients are changing. And Doppler, at the one hand, we have blood pool Doppler, right? Continuous wave, pulsed wave, come back to that in a minute. But we also have tissue Doppler, where we can actually then look at the velocities of the myocardium and try to get dynamic information from that also. Besides these kind of point-wise measurements of velocities, we also have like more like the visualization of the flow within the ventricles. And we have the color Doppler, so the blood pool color Doppler, which is, of course, particularly interesting to look at flow patterns, and especially look at flow accelerations, regurgitations, and things like that, because our eye is very good at perceiving color patterns that can help in order to do it. Quantification based on this is much more difficult. Nowadays, people are trying to do this more and more, and especially when we go to MRI, for example, 4D flow, we can try to quantify more. But for the rest, even visually looking at this is quite interesting. Like here, for example, as an example of, so here you have the left atrium, you have the left ventricle. Normally, you have color flow where kind of red flow is towards the transducer. Right? So towards the transducer in a sector image is towards the kind of the point of the triangle. And blue is away from the transducer. And of course, when we have turbulence, where we have velocity vectors in all directions, in this case, it's kind of shown as green, as the combination of blue and red. So here we have a very turbulent pattern. And also, while there's blue going towards the aorta, there should be no flow towards the atrium. And here we clearly see there's a jet of turbulent flow going into the atrium. So it's clear that there's something wrong with this mitral valve and there's a hole. So these are easy ways in order to look at it. We can look at 3D Doppler, but as I mentioned before, while 3D is nice and 3D is probably the future at this moment, technology in ultrasound and actually also MRI is such that frame rates and spatial resolution is still relatively low, and that it's not always easy, but by integrating data, I think we still can get most out of it. So when we use quantification of Dopplers, there's actually two basic physical principles that are being used a lot during measurements. And one is what they call like the continuity equation. So which means that if we have a flow and we look at different positions in space, then if there's no source or drain of flow, then that means that the same amount of volume has to pass at each position. So that means that the volume flow, the local volume flow, which would be the velocity times the area, should be the same at each position. Okay? So, and if we look at narrowing, so it's particularly useful for stenosis, for example. So if we can measure velocities at different places and measuring, for example, the area of a stenosis, directly measuring it is extremely difficult. We don't have the spatial resolution in our imaging in order to measure this. So what you will see is that we try to do this indirectly by measuring an easy diameter, measuring easily flows with Dopplers, and then calculate by continuity of flow, try to calculate the missing area. Besides continuity, yes?
A small question. Then we are assuming that the flow is constant, the velocities are constant along the area?
No, we can do that dynamically. I'll come back to that later on. So the continuity equation is actually you can put a t, yeah? So, but you need to look at the velocity as a function of time and the area as a function of time, and they're always related. That's the point.
I mean, if we are doing like a pulse wave Doppler, then we are only getting the velocity in a point, in a single point.
Yes. Well, yes and no, in the sense that we always have a sample volume. So we have it more or less over an whole area. And the other thing is also, what are the flow profiles that we're looking at? So what we assume actually is that within the heart, we mostly have actually flat velocity profiles. You know, in a tube, you always have a parabolic profile. But if we look within the ventricle and within the valve, actually the profile is relatively flat. So in that sense, even if you just measure in one position, you can extrapolate over the whole kind of surface that you're looking at. Okay, so besides the continuity equation, and also, which partially answers your question, is in clinical practice, we simplify things a lot, and sometimes too much. And this is also where some research is going to. Similarly with the Bernoulli equation, so Bernoulli equation is linking pressures and velocities at different points. And when we look at it, so we look at 2 points where we do a measurement of pressure and velocities, they are linked to each other by actually a convective acceleration, there's a flow acceleration, and there's a viscous kind of friction. You will see that this complex relation is actually the physical relation, and you can prove that. But what we will see is that we again will simplify this a lot, but I come back to that in a minute. But these are two important physical hydrodynamic principles that we use. Now, what is Doppler information that we use? So at the one hand, we have continuous wave Doppler, and continuous wave Doppler, what we do is with our transducer, we continuously emit a very narrow bandwidth, so like a sine wave, more or less, and we continuously receive this. So what we do is, because of the fact that we have a narrow band that we send out, what we can do is we can actually measure the real Doppler shift induced by velocity of reflectors. And this way we can measure the velocity. But with the biggest disadvantage is that we don't have spatial information. So we measure all the velocities which are present in this scan line at the same time. Now, luckily, or actually this is the way we use it, we use this to look mainly at valves. And when we put our scan line in this apical view, for example, from the apex towards the valve, in this case, the aortic valve, what we know is that actually from anatomy, that the highest velocity will be actually within the valve. So if we look at this Doppler spectrum, while we don't know which velocity is, what we assume is that actually the highest velocity, so the envelope, is actually within the valve. That's mostly true, but sometimes, for example, what you can have is you can have membranes, kind of supraortic membranes, for example, and then it might be that this is not completely valid. So again, we have to take care that we keep this in mind when we do this. On the other hand, we have pulsed wave systems where we actually can put a sample volume at a specific place, and we actually only measure the velocities which are present there. So what you see here now is that this envelope with a certain range, you see that now the middle is not filled anymore. So we really have like a kind of certain envelope. And actually this range of velocities is what is within the sample volume. Again, this is not one velocity because of the sample volume has a certain size. And roughly again, in ultrasound, this would be, in adult ultrasound would be 1 square centimeter, roughly, that you're actually measuring it. And so this kind of the white area is the velocity that is present there. Again, the envelope would be the maximum velocity that is there. Big advantage of this is that really we can measure velocities at a certain position. The disadvantage, what you can see here, is that they could be aliasing. So because of the way that it works, what happens is if the velocity is too high, which is related to the pulse repetition frequency that we have, what happens is that we get wrapping of velocities, and you get this type of images where actually velocities are wrapped. Now, there are some tricks to unwrap it, but very often it doesn't work, at least not in in clinical practice. So that's why we actually use these complementary, that when we have extremely high velocities, then we measure the continuous, or we use the continuous wave, because it's much better to measure high velocities. When we look at certain velocity profiles, specifically at specific places, we use pulsed wave Doppler. But we have these both. So here you actually see a very nice example in this continuous wave, where you see that you actually can pick up two profiles at the same time. So here you see that there's actually two velocities that you measure, and that is often, like, for example, if you have a membrane or if you have something. So again, keep in mind how you use this. But this interpretation later on, we'll come back to that also. Now, one disadvantage of Doppler, the way it's done with ultrasound, is that you can only measure the velocity component, because the velocity is actually a 3D vector. So it's, as I showed you with this MRI visualization, velocity can be very complex when you have these vortices within the ventricle, or when it becomes turbulent, for example. So it's a 3D vector. And with Doppler, what we do is we measure the projection of this vector on the scan line. So we can only measure the component on the scan line. So obviously, depending on the angle of our Doppler scan line with regards to the direction of the flow, we can have some artifacts. And what you see here is that looking at these profiles, so here you see a nicely aligned profile. So in this case, this is an aortic stenosis. So you nicely see an envelope, you can measure the highest amplitude. And if you change this angle, you see that actually your Doppler becomes messy, and you can't measure anymore the proper envelope. So this is really important during acquisition to make sure that this is aligned properly. With MRI 3D flow, or 4D flow, as they say, as a function of time, you can partially avoid this. Again, then you can really look at the right angle, or the angle that the vector has, so the really 3D vector. The problem, as I said before, is potentially the temporal resolution. So because of lower temporal resolution, you might then miss a peak. So there again, these are complementary techniques in some ways. Now, besides this, which is kind of physics technical problem of this angle dependency, is actually, it also depends on what Doppler do we want to measure. And there it's quite important to look at the dynamics of the heart. So for example, what is important for looking at diastolic function is this mitral flow pattern. So as we said before, you have this early flow, you have this late flow. And as you will see, as people are measuring, for example, the ratio between the peak of the early and the late flow, what we also look at is at, for example, deceleration times or temporal timing of these flows. So it's important that we actually measure this at the right position. And when you look at kind of physiologically and morphologically, as we said before, so you have continuous flow in the ventricle, but of course the flow in the ventricle itself starts to spread a little bit, and you start to get this vortex and reverse flow. So now, depending on in which position you actually measure of the ventricle, you actually see that you get different profiles, different measurements. Also, when you would do learning, for example, based on these flow patterns, then it's really important to always have it at the same point. The clinical kind of consent is to measure it in between the tip of the mitral leaflets. So this kind of D position, this is the position that we measured. But also keep in mind that what I said before is that during contraction, what happens is that the valve plane moves towards the apex, while our Doppler position is, of course, not following. So actually, when we measure this, what we do is actually within the heart, we see that the sample position is actually changing continuously. And the more longitudinal function we have, the more it's changing. Now, partially here, we are lucky again, in the sense that what we said before is with most cardiac abnormalities, you have less of this longitudinal displacement. So the sicker the patient is, actually, the less this is of a problem. But okay, that's in a way lucky behavior. But this is important to know. Now, what is also important is, of course, that especially at the end here, when we look at the dynamics of the A wave, is, of course, the more we measure in the ventricle, even if the valve starts to close, we have continuous flow in the ventricle because of this vortex that forms. So the timing, and that's what you can see here, is this timing of this aortic flow, of this mitral flow during atrial contraction. You see within the ventricle, it seems to last much longer. But here, at this end, you're measuring the vortex within the ventricle, while, of course, when you're purely in the atrium, you're only measuring what's happening in the atrium. So again, also, this is important. And what actually some people are saying, and that's what's been done in the past, unfortunately not anymore too much, is that actually you should measure at different positions. And then depending on which component you're looking at, you want to use different data. Here again, if we would have a full 3D, 4D acquisition of the velocity vector over time at a high spatial temporal resolution, we could partially avoid this by really tracking. But currently in clinical practice, we don't have that. So this is another source of variability, of course, of the shape. Okay, so how do we then use this for measurements? I partially told you before already. Volume rates, what we can do is if we have a cross-sectional area and we measure the velocity, we can calculate the volume flow. What we often do is we measure an average velocity, or we measure the velocity time integral. So what you do is you actually delineate the velocity as a function of time, and then you make the integral each time kind of multiplying by the area. What we do for the area, though, is what we mostly do is we measure the diameter of the valve or of the kind of outflow tract, for example. This has two problems in the sense that when you measure the diameter and then assume that it's circular, then you assume that the valve is a kind of perfect circle, perfect disc, which is not the case. The aortic valve is roughly circular in diameter. The mitral valve is very elliptical in some ways. So when you measure it there, that's a simplification. And the other thing is that although the diameter of the valve, the area of the valve is not changing a lot during the cardiac cycle, there are some changes. Again, the aortic valve is much more static, but the mitral valve, at some point we might come back to that, it's not only elliptic, it's actually like a hyperbolic kind of surface. And it's actually also changing dynamically during the cardiac cycle and during the filling, partially because of this ring motion that we have. But as I said before, in clinical practice, we're gonna simplify this. So a very simple way is we measure the diameter of the valve, we calculate the area, we measure the flow velocity integral, and by multiplying these, we have somehow the cardiac output. So what we have then is we have the stroke volume. So the stroke volume is what's the amount of blood with each cardiac cycle that's being ejected. If we multiply that by the heart rate, we have what we call the cardiac output. So that's the amount of blood per minute that is circulating. So that's in the end what the body needs. And then we often index this because, of course, a larger body needs more blood flow than a smaller body. And what we often do is we normalize it by body surface area. Now, why body surface area? And that's more like, that's partially related to the fact that the energy consumption of our body is actually related, or is a lot related to the energy loss or the heat loss, for example. And heat loss is, of course, determined by surface. That's where you see, for example, the bigger the species or the animal is, the less energy consumption is needed. When you look at, for example, very small birds or very small mice, for example, they consume an enormous amount of energy because they lose so much energy because of the fact that the area compared to their volume is extremely high. When you look at an elephant or whale, for example, they have a relatively small surface with regard to volume, so their energy consumption is actually lower. So that's why we use body surface area as like a rough estimate of energy that is needed. And that is, of course, then translated into the cardiac output that is needed for a certain body. Is this ideal? Not particularly, but it is what we have. So, and that's why it's more or less standardized. So here is an example. So what we do is we take an image of the aortic valve. So in this case, that's a peristernal long axis view, where we can measure the diameter of the aortic outflow tract. What you see already is that this is not always easy to measure. So it's very easy to make a measurement error based on this. So, and especially, of course, since we have to kind of calculate an area based off this. So every small error will, of course, be multiplied when we measure the area. So we measure this. Then what we do is we measure the time velocity integral of the Doppler, again, with all the problems of the positioning of the Doppler and things like that. And so based on this, by multiplication, what we can do and multiplying then by the heart rate, we can actually really know or measure the cardiac output. Similarly, what we can do is we can use this indirectly also to measure regurgitant volumes. So because if we have, for example, a leaking mitral valve, so what happens is flow comes into the ventricle during filling, and during ejection, flow goes into the aorta. And normally we hope that everything goes into the aorta, but if we have a leaking mitral valve, some of it goes into the mitral and into the atrium again. Here in this case, we see an enormous regurgitation where double the amount of blood would go back compared to the aorta. So that means an enormous volume overload of this ventricle. So with every heartbeat, this heart has to eject the volume that goes to the body plus the regurgitant volume. So what we can do is actually we can do a continuity equation based on this. So what we can do is we can measure the mitral in, then we can measure the aortic out, and then we can estimate the regurgitant area and regurgitant volume of the mitral valve. So this is a way to do this. So as we said before, we do this for direct measurements. We do this indirect measurements for stenosis, for regurgitation. So these are the ones that we can use. There's a couple of other ways to use it. So as I said before, continuity equation is one. What actually you can also do is if you want to measure a stenotic valve, you can even do continuity equation between the outflow tract and the valve itself. Because as I said before, directly measuring a stenotic area is very difficult. Measuring the outflow tract is, in brackets, relatively easy. There's a reasonably large measurement error, but at least it's relatively easy. And then measuring the highest velocity within the valve is also, again, relatively easy, especially with continuous wave. And we can, with pulsed wave, can measure the velocity here. And this way, we can do an estimation of the area. Now, another way that people have been proposing is what we actually can do is we can actually do a continuity equation based on what we know about the dynamics of the flow. So if we would assume that going from a very large ventricle into a small hole in the valve, if we assume that the flow would converge in a spherical way, so that we say that there's a certain sphere with a certain velocity, so the velocity will become the same and will accelerate according to the spherical distribution. What we can do is if we can identify the position of a certain velocity and we can measure this radius. So what we can do is we can calculate the area here. We know the velocity and we can measure the velocity here, which means that again, we can calculate the area. And it's actually quite easy in some ways to determine the position of this plane by looking at aliasing. If we do color Doppler and we turn down the velocity range, what you start to see is you start to see these color rings of a certain velocity, and then we can measure the distance, and this way we can do it. So in theory, this is a very neat way in order to do it, which is practically implementable. The problem is that actually in reality, we very rarely have this really spherical kind of convergence pattern. And even if the hole is in the middle of the valve and we have a nice homogeneous convergence towards this, it's not spherical. And next, of course, many of the lesions that we have are actually asymmetric, and it doesn't work anymore. Again, there is some research in order to do this more properly, is identifying these kind of surfaces in a better way and then calculate the area in a better way. But everything is complicating things, and it has never been kind of shown that this is an easy way in order to do it. That's why for research, people are using it. In clinical practice, a little bit less. The other thing that I told you before is, of course, the Bernoulli equation. Because with the Bernoulli equation, what we can do is we can measure pressures. And what you want is, of course, also in order to look at the dynamics of the, for example, especially a stenosis, in order to look at the impact of the stenosis, what's important to know is what is the pressure drop, the extra pressure drop that this stenosis is causing. Because this is the thing that, of course, is important, because that's extra pressure that needs to be generated by the ventricle. But that also gives us an idea about, of course, the change in the diameter. So, as I said before, we have this complicated Bernoulli equation. And in order to do this, to really solve this equation, what we need to do is we need to measure velocities at two different places. We need to know the density of the blood. We need to know the derivative of this, and we need to know something about friction. In clinical practice, what they say is like, well, this is too complicated, let's simplify. So let's first say there's no friction and there's no kind of energy loss in the acceleration. So let's say we only have the convective kind of flow. So that simplifies already this. And then we can say next is like, yeah, but this velocity here, the first velocity, this comes from a very large ventricle into a small valve. This is going to be a very low velocity, much lower than the difference there. And since it's being squared, if this is a low velocity, we can actually even ignore that. So what you say then is that actually the pressure difference is half of the density by the velocity in square. We assume a certain density. Again, that's not looking at how blood might change in different patients. But so we kind of make a simplified Bernoulli equation where we just measure the high velocity within the stenosis, and we then assume that it's 4 times the square of this is actually the pressure difference. This is used in clinical practice. This has been shown to be very useful. But the problem is, of course, that this is simplified. And nowadays, I think we can do better. But still, mostly, this is not being implemented in clinical practice. But it's important to know. So we don't use viscosity, and we ignore the temporal kind of changes, the acceleration changes. And in some pathologies, this can actually be quite important. So here is an example where you measure the maximal velocity. And based on this, you can actually measure the pressure gradient. Keep in mind that this is the kind of instantaneous pressure gradient that you do. So there's some research on that this is like a difference. This is not necessarily the maximum. This is not necessarily the gradient at maximal pressure, but this is the maximum gradient during the temporal behavior. That's important. So this is also, again, while it's important to keep in mind that Dopplers are pressure gradients by definition and not pressure profiles. So you can't use it for that. Okay, yeah, here again, you can do that and you can look at the dynamics. This is not so important. Now, another thing which is important also, or which is useful, is, of course, looking at the dynamics of this pressure change. Because, for example, if we have a mitral stenosis, so where it's more difficult for the blood to go from the atrium to the ventricle, what happens is that filling becomes slower, which means that it takes longer time for the pressure between the atrium and the ventricle to equalize. If you have a mitral valve which opens very quickly, we have an almost immediate pressure equalization. That means that there's no pressure gradient anymore. That means that the velocity, of course, rapidly changes. And the slower the velocity decreases, the bigger, of course, the stenosis, is in between this. And this is actually a way by measuring the dynamics, so the pressure gradient, by, for example, measuring the pressure half time. So this is one of a way to do it. We can actually measure this. So that means that we can measure the differences between all these different pressures, and all of these are interesting to look at filling, to look at outflow, to look at the right side, to look at the left side, and so it gives us some dynamics. And similarly, also by looking at this dynamics, and that's the last example that I'm showing what you can get with Doppler, and also why it's important to look at all parts of the Doppler profile, of course. So not only does the maximum velocity tell us something about the maximum pressure gradient that we can have at some point, but this kind of slope will tell us something about how fast the acceleration is taking place, and thus actually how fast the pressure is changing, how fast pressure is being built up, for example. So what you see here is if you have and in this case, what we're looking at is if we want to look at the pressure increase in the ventricle during the contraction, if we have a mitral regurgitation, in this case, a very small leak in the mitral valve, so we have actually blood going back, and we see it's like when blood is accelerating, we know that the pressure is building up, and that actually the derivative of this will be the derivative of the pressure, of course, related to the fact that velocities and pressures are related. So that means that we can actually measure a kind of derivative of the pressure by measuring how fast this goes. And so here's this very small example. And this is actually a patient with a dilated cardiomyopathy and heart failure. In this case, because of an arrhythmia, because of a dysynchrony and left bundle branch block. So what we see here is that looking at this profile, this is actually going up very, very, very slowly. So that means that the pressure buildup is very slow, very inefficient. And here what we see is this is after therapy, in this case, cardiac resynchronization therapy. We come back to that later on, what it does, but what you can clearly see is that in this Doppler, you see that the slope becomes much, much higher. So you see that the derivative here of this pressure becomes higher. And so you know that the contractility of this heart is actually more important. So just to conclude, is using Doppler and or the dynamics of velocities measured by whatever technique, but in clinical practice, Doppler is the most used. We can get actually quite a lot of information, which is relevant to look both, or to describe both the ejection as well as the filling of the heart. And that's related to measuring volumes, stroke volumes, and regurgitant volumes because of leaking valve, because of shunts and things like that, to try to estimate stenosis areas, so areas of valve stenosis or areas of regurgitation, for example, to measure pressure differences, again, which might be related to stenosis or regurgitation, or can tell us something about filling. So because filling and ejection are related to these pressure gradients. And when we look at the dynamics of the velocity over time, we can actually have some implication on how the pressure is being built up, which is then related to the force development within the ventricle, and thus related to contractility. Okay, that's today's kind of information on Doppler. I don't know if any of you have any questions.
Yeah, I wanted to know. Thanks for the lecture. I wanted to know if you have a way of estimating your errors in these types of measurements. Like, no, I mean, at least to know if your error bars are like so big that your measurement has no sense at all, and you could be making a dangerous assumption.
Yeah, I think this is an extremely good question. This is something which is actually lacking mainly in medicine cardiology. Currently, this is not being used, let's say it that way. And I think it's something that we should do. And this is partially up to researchers and companies to do. Now, the problem is that the sources of errors are huge. One thing is, for example, the sample volume that you're using for Doppler. And the sample volume and even the spatial resolution, especially lateral resolution or the in-slice resolution of ultrasound is not so great. And we could actually indicate this error, but the problem is that the companies are not eager to show how bad their systems are in some ways. So in that sense, it's not being done explicitly. Cardiologists actually, by experience, you know this, you implicitly actually use this. This becomes important when we start to use modeling or machine learning. Then we assume that we have accurate measurements, and actually we don't. Clinicians implicitly take this into account. So this is one thing to really keep in mind. The other thing is, for example, also your error because of the angle of Doppler, we don't know. And that's something which is extremely difficult to estimate because you would need to know the anatomy because of this. So you would need to combine information. But even then, it's like related to sample size, then related to using certain simplified equations. I think we could estimate this, and I think we should in the future. And I think at some point we have to try to take this into account when we provide measurements, but you're totally right that this is not done properly. So